Hello friends, I am Dr. Makarand Anil Rane. I am an obstetric physician. What is an obstetric physician? I work in interface of both these branches, medicine and obstetrics. I actually take care of medical disorders that occur in pregnancy. And second part is I take care of pregnancy in women who already have some medical disorders. So we'll see what are the parts that I take care of. Or before that, I'll start with how this concept came in my mind. I had a core interest in subject of obstetrics, but I somehow take admission to Department of Medicine for my post graduation. During my course in post graduation, what used to happen is we used to get different calls from Department of Obstetrics to see medical disorders, and I had core interest in obstetrics, so I used to see more frequently to the department. And later on I realized that we as physicians are not totally capable of managing obstetric population, because all the diagnostic criteria are different, lab parameters are different, physiology of that pregnant lady is totally different, managing protocols are various, managing guidelines are different at international level. So I felt myself of incapable of treating that patient during my first year. Then I started reading later on. Second thing which struck in my mind, patient used to come which were having some diseases like epilepsy or psychiatric disorders. They were used to be on some medicines, and the drugs used to be either of category C or category D, and I really used to have a doubt whether to continue these or to discontinue this. I cannot continue because they have side effects on babies and pregnancy. I cannot discontinue because mother is going to suffer with increased amount of those diseases. That is how I started reading more and more into these obstetrics. Later on, we started seeing acute patients in pregnancy, acute medical complications such as jaundice complicating pregnancy, dengue in pregnancy, a woman with some heart related condition getting pregnant, some lady who is having dialysis and she is getting pregnant. For these, they are already on some medicines, they land up in ICU, and we as a physicians don't have that insight to think of baby which is growing inside the womb of baby, inside womb of mother. So what we used to do is we used to focus on mother, manage them, their critical conditions, stabilize and then send back. But meanwhile, what happens to baby? Are these critical conditions survivable to baby? Are those medicines to be compatible to those growing fetuses? We never had those doubts. That was a problem. Later on, as I started reading about it, I started gaining some maturity. Then I started considering fetus also, and so that approach completely changed. I consider myself as an assistant between an obstetrician and a super specialist for patients who are already diagnosed. For example, a girl who is already diagnosed with epilepsy on antiepileptics and under follow up of some super specialist neurologist, a girl who is having type 1 diabetes, who has married and who is on insulin and planning pregnancy. The doubts are many and nobody is going to take care of those doubts, whether to continue insulin, whether to shift on other type, what will be the glycemic control in pregnancy, what will be the actual side effects, how to prevent that hypoglycemia. There are n number of doubts, nobody used to bother. And for such patients, what used to happen is obstetrician used to refer patients to physicians, physicians to refer back with some doubts to obstetricians, and patients used to suffer. Ideal is a common setup where obstetrician is there discussing things with super specialist and conveying message to the pregnant lady and her relatives. But what happens in our scenario, patient is having some medical disorder under some super specialist, obstetrician writes a letter to give fitness. That super specialist it is not his job to understand these problems. He gives fitness. The lady goes with the same medicines to obstetrician. Obstetrician says, okay, fitness is given, continue the same medicines. There are differences in safe medicines trimester wise. There are changes in doses. We need to modify the doses according to trimester, according to weight of mother. to prevent the complications. Along with that, this was all about pregnancy. When things reach near delivery, there are n number of other issues, whether she can go ahead with a normal delivery or a cesarean section, whether she can have spinal anesthesia or general anesthesia in case of cesarean section, whether she can have any other related complications or not. And it is obstetricians and hospital staff's job to know what are the complications and be prepared for that. And it is relatives' right, what are the expected complications, what will be the social burden, what will be the economical burden, and that is my job. I take that responsibility. I discuss things with obstetrician, I plan out things, and collectively I deliver those things to patients' relatives. I have a few cases who were having critical medical disorders and they were advised not to conceive, but being a lady, it is her birthright to become mother. How will she become mother? After giving birth to baby. If we don't allow her to conceive, we are pulling her birthright to become mother, and that is something struck in my mind. I started working on that, and now high risk mothers have started coming who already have some serious renal disease, some serious liver disease, some complicated heart disease. They come to me. I do a proper pre-pregnancy counseling. I make them understand what are the actual issues they are facing, what is the disease they are suffering, what are the medicines they are consuming to prolong their healthy life. Then I make them understand what are the effects of that disease on pregnancy, what are the effects of medicines they are taking on growing fetus, how the disease is going to get modified because of pregnancy. And once they agree that they are acceptable to these complications which are going to be there in future, I take a proper consent and I shift their unsafe medicines to safer medicines, and then I advise them to follow up after 3 to 4 months. Once I have confirmed that they have been stabilized in last few months on safer medicines at safer doses, then I allow them to conceive. Once conceived, it becomes my responsibility to take care of medical aspects of their disease in pregnancy. Routine follow-ups are advised, a proper battery of investigations are advised to be done at proper intervals, and accordingly proper steps are taken to prevent the related complications. At times we have to abort the pregnancy to avoid further complications to baby and the to-be baby. These harsh decisions we have to take to prevent the morbidity and expected mortality. But once things are safe, I let them conceive. I continuously monitor them till things are at a safer level. Then my next role comes when she is about to deliver. I arrange a second meeting with them. I discuss her present status with the obstetrician, how things are going to be managed, what are the expected things, what is the advised preparation for that delivery, what is appropriate setup for delivery or cesarean section of that critical mother, what are the immediate requirements of baby to be taken care by a neonatologist immediately after delivery. We plan those things and we deliver these things to relatives accordingly. This is my role, and I am usually confused as obstetrician, which I am not. I am not at all involved actively in normal deliveries and cesarean sections. Second person I am commonly confused with is fetal medicine person. I am a physician, MD medicine. I cannot do scans. My role with a fetal medicine person is just to advise what additional things they need to see in the scans. I am an obstetric physician. I take care of medical disorders in pregnancy, right from fever, dengue, COVID, heart, kidney, liver, lung, n number of medical disorders for where you have to visit a physician. But in pregnancy. And my major role is to preserve motherhood with advancements in technologies, increasing stress and increasing parental age in our generation.